key message is they're not trying to be difficult. And that the point of today is that obsessional behaviours and these obsessional conditions are about kids trying to feel safe. So that's a takeaway from today. So the child who washes their hands repeatedly, the teenager who checks the doors 20 times before they go to bed, the young person who pulls out their hair when they feel distress. These behaviours, we often interpret them as voluntary or irrational, that we can just stop it. But if we look closely at the developing brain, we can actually see that there's more to this than meets the eye. We see a nervous system that's basically discovered a strategy for managing their distress in a way that's not so helpful to them. So we're going to explore these three ideas today. We're going to look at the neurobiology of OCD. We're going to talk and think about how trauma and neurodivergence interact with brain circuits that leads to this condition. And thirdly, as you know, my bias and bent is the fact that there's a power in the parent-child relationship that can help relieve symptoms and help their development. And the central message today is that children don't choose to behave that way. Their nervous system has discovered a coping strategy. So let's talk about OCD, that there's a reasonable prevalence, 2 to 3%, and we'll talk a bit more about why and when it peaks, but there's peak in late childhood and early adulthood. But it's about the brain's attempt to manage perceived threats through compulsive rituals. Okay, so that these are automatic ritualistic compulsions rather than a child choosing or a failure of willpower to stop it. So it's important for us to understand these behaviours as adaptive responses, and also to think about compulsions as they're not irrational habits, right? They are driven by neurobiology. Let's think about OCD. What is OCD? So OCD consists of two interacting components. So obsessions are intrusive thoughts, images, or impulses that create distress. So that phrase, ego dystonic, means that it doesn't, it's an old Freudian term that suggests that it doesn't sit right with your ego. It's not in line with your feeling or your want. It's not comfortable. You don't want it. And it causes significant anxiety. There's a rising anxiety, and then there's a compulsion to perform a repetitive behavior or a mental act to reduce the distress. And that the key word here is the word temporary, right? That it leads to a temporary relief from compulsions and that anxiety. But then there's a pattern because it's only temporary. So then the thought returns, and the relief will only last for minutes or sometimes seconds. But that short moment of relief is enough for the brain to learn something really powerful, which is do that behavior again. And that behavior becomes reinforced. If you do that again, it'll relieve the anxiety, and the whole cycle will loop. And over time, the loop becomes automatic, and there's nothing that they can do about it. And part of understanding why this happens is we need to think about brain circuits. Right? And our best understanding of OCD brain circuits is this circuit that involves the frontal lobe and the limbic system, specifically this corticostriato-thalamocortical circuit. So it's the cortex, the striatum, which I'll talk about in a minute, the thalamus, and back to the cortex. And there's a loop that happens that they can't help. So the CSTC is pretty much is our way of understanding OCD, and it's quite amazing because there's very few mental health conditions that actually have such a good neurobiological basis as OCD. OCD is one condition that we have a reasonably good understanding of. And this CSTC loop, as I mentioned, involves the orbitofrontal cortex, which is at the front of your brain, the anterior cingulate cortex, which is just inside that, and the striatum and the thalamus. So these regions, they communicate continuously in loops, And the loop itself, if we go back, let me see if I can go back. The loop itself, yeah. The loop itself actually has some function. So there are some critical functions that this cortical loop does. And the functions are, it can detect potential problems. It decides whether action is required once we detect the problem. And it's meant to terminate the behavior that you've done to solve that problem once your problem is solved, right? This is the function of, that's the function of that loop. You detect the problem, you do something to solve it, and then you send a signal that says we don't need to do that anymore. In OCD, something goes wrong with that system. And that's basically the nature of OCD. So instead of switching off once the brain believes a task is complete, the signal keeps firing and the loop keeps continuing. Right? The brain continues to send the message, something's wrong, fix it again. Something's wrong, fix it again. And the neuroimaging studies are pretty consistent with this, that there's abnormal activity in these circuits. And what this circuit does is it's meant to help regulate how do we form habits, how we select specific actions, how we detect errors, how we detect problems. But in OCD, instead of that being a regulated, rational, mature system, it just is overreacting, right? And it constantly detects errors, even though there's no threat, right? So, which is similar to our understanding of an overactive defense mechanism, right? So what's the nature of anxiety? Nature of anxiety is that our brain detects danger when there isn't, and we act like we're in danger. Make sense? All right. So if we focus a bit more on the anterior cingulate, so the anterior cingulate cortex is this bit here, right, just behind the main part of your frontal lobe. So what that does is this region is meant to monitor for mistakes or potential problems, right? So it's our kind of detector for, well, there's a problem here, right? There's an error or there's conflict that's happening. And if you have OCD, this part of your brain is highly sensitive. It's overly sensitive. And if we scan your brain, we'll see that there's increased activity in this region during tasks that involve you needing to detect if there's an error happening or if there's something that's not right. So the brain essentially behaves as if a mistake has occurred even though nothing is wrong. So it's like your smoke alarm going off every time you make toast. Right? The system works, the alarm works, it's just too sensitive. Right? So it exists for a good reason, but it's too sensitive and it's detecting errors when it really isn't, that doesn't warrant the response that it's giving. So, and what it feels like for someone with OCD or someone with a hyperactive anterior cingulate is something doesn't feel right. Right? And in old terms, you used to call this that kind of primary psychotic symptom, where you just get the sense that something's not right with the world, and that seems to be the beginning, and then your brain creates stories and experiences that build on that, right? And it's really, and this thing is like, because the rest of your frontal lobe is still functioning pretty well, the person knows that what they're doing doesn't make sense. Like there's a knowledge of irrationality, but you still can't stop it, right? So that's a really key point, right? That even though, because how frustrated do we get with kids who's, you know this is not right, but there's nothing you can do about it because they still do it anyway, and they genuinely can't help it because of the nature of the automatic nature of this problem, right? Now, the orbitofrontal cortex, which is orbitofrontal means it's at the front near your orbits, which is near your eyes. What this does is this region evaluates risk and predicts negative outcomes. Right? So it makes decisions and has some sort of behavioral flexibility to make around that decision. To go, do I do this or do I not? That's what it's supposed to do. But in OCD, that doesn't work so well, right? So the orbitofrontal cortex works with temporal lobe structures and other parts of your brain for body awareness and sensory processing to detect, right, to detect risk and negative outcome, but it's a bit too sensitive. So what it does, what the orbitofrontal cortex does is asks the questions, the type of questions it asks are, what could go wrong? You know, I think we're pretty familiar with that question. And what should we avoid? What should we avoid because something bad might happen? That's what it's meant to do. And when this region is hyperactive, it overestimates potential risk and overestimates potential harm. Right? So, and what it means is that even minor uncertainty, like a change in routine or moving from one activity to another, that's a really minor uncertainty. It becomes experienced as a significant threat. Right? So we're now starting to build this picture of, you know, say the child who's neurodivergent. How many times do we talk about this resistance to change and how change leads to this over kind of too big a response, too big an anxious response. And they become obsessed with it, right? With minor things, they become obsessed. So this is, the orbitofrontal cortex is in charge of the obsessions with, well, what if there's germs? What if it's contaminated? Right? Or what if I hurt someone? Right? How many kids do we know who've got these obsessional fear that they might hurt somebody, or I'm bad, or a fear that I'm going to make the biggest mistake and embarrass myself, so I'm not, like, you know, that really classic social anxiety. I'm going to do something to embarrass myself, and everyone's going to laugh at me. Right? So they're the kind of thoughts, they're the kind of anxieties and thoughts that the orbitofrontal cortex is meant to make decisions around, right? And it's meant to have some behavioral flexibility around how you manage those fears. So because your brain is attempting to prevent imagined harm, but it does it by generating repetitive thoughts and behaviours instead of being flexible. Right, so we'll go more into that. Now, the striatum. So the striatum is part of your basal ganglia. So for those of you who don't know what a basal ganglia is, it's in the middle of your brain and it's in charge of coordinating things. Coordination. You know, we usually think about the basal ganglia as coordination of movement. So basal ganglia disorders will mean that your movements won't be smooth. So movement disorders will be part of the basal ganglia, but it also moderates and coordinates thoughts and emotions. Okay, so that's the role of the basal ganglia. And one of the roles in the striatum, which is the part of the basal ganglia, and it's called a striatum because on a microscopic slide there's stripes on it. That role is about habit formation, right? So when a behavior reduces distress, the striatum says we need to keep doing that behavior because that helps us feel better. And this is the part of our brain that learns through reinforcement. Okay, so we feel upset, we feel distress, we perform a ritual, anxiety reduces. The striatum records that sequence and then comes up with this conclusion that distress means I do this behavior, means I get relief. And then that behavior becomes automatic. Okay, and there's a few neurotransmitter systems that are kind of implicated in this. That glutamate is a stimulator of the striatum, and it causes release of GABA, which then inhibits the actions. But then there's something there's abnormality in the release and modulation of glutamate, as well as serotonin and dopamine in this area. So there's something happening that's abnormal something has happened where the striatum has developed abnormally. So instead of it being able to develop good habits or being able to help the rest of your brain work out which are the right behaviors or actions or thoughts to do, because it needs to link in with the frontal lobe. The frontal lobe needs to make that decision. But if the frontal lobe needs to say, hey, in this scenario, this is what I will do, and the striatum says, yep, that's great, we'll put that as a procedure, and then your brain will be able to do it quickly. That's how our brain works, right? Because it's like you driving a car. After a while, you don't think about every little step anymore because your brain has created a procedure. So the striatum's got one of these, is part of that function, is to help create those procedures. But if the procedure it's created is you feel anxious, you do a ritual, you feel better, that's going to get stuck. Okay, along with inflexibility of your frontal lobe. So there's, so we're starting to paint this picture that these different areas all together are not working efficiently, yeah? And most of the research now is actually pointing towards that it's not just about this circuit, right? There's actually lots of integration with your cerebellum, with the other parts of your prefrontal cortex, your amygdala, which we know about, your hippocampus that we know about, right? The hippocampus consolidating threat memories and adding context to your experience. For years, we used to think it was just purely about the CSTC, but it's not. We actually know that all of these systems influence memory, processing fear, cognitive flexibility, being able to make different decisions. And the research that we're seeing now is actually that there's actually a much broader implication of brain systems. And that's important because remember that one of the things we know about neurodivergence is a weakness in brain integrative networks, particularly long distance networks. Remember that one of the things we know about ASD is that local networks are particularly strong, but long distance networks that integrate other brain systems are not strong, which makes them much more prone to having this loop causing them a problem. Make sense? Now, when does it happen? Right? So we know that there's basically, it's fascinating because the age of onset of distribution of OCD appears to be when there are times of peak brain development, when your brain's changing, right? So obviously in early childhood, you've got this rapid growth of your brain. Your brain's just constantly changing. And then there's a sort of a relative period of stability once you move into adolescence, and then in adolescence, you then go through this pruning. Okay, so remember that in adolescence, your brain changes again, right? So you get this rapid brain size growth at the beginning, and then your brain shrinks in adolescence as it starts to reinforce the areas of your brain that you need and get rid of the bits that you don't use, right? So it's interesting that we think about this, that for some, that the peaks of age of onset of OCD seems to be during these times, which suggests that that this is about delayed maturation of these circuits, right? Or change in these circuits, or there's something that that there's an immaturity in these connections that leads to poor control, poor inhibition of repetitive behaviours, and that during these moments when your brain's still growing or when your brain's changing quickly in adolescence, you have less capacity to suppress repetitive impulses, right? So if there's a circuit that's happening in your brain, you have less capacity to regulate it because your brain hasn't matured enough yet when you're little, or your brain is changing, and so your regulation systems are evolving in that time. And of course, there's also the issue of environmental stress, right? That because environmental stress will interact with genetic vulnerabilities during these sensitive periods, and that will add to this picture, right? So we often talk about this sensitive periods of development in early childhood, and then again in puberty, and again in adolescence. And these seem to be peak times when we can see that the child's ability to regulate whatever abnormal circuits are going on becomes less. And that's probably why we see the onset. And I think it's pretty easy and clear to draw the line towards what happens when you experience trauma, because trauma in attachment contexts just derails the child's emotional regulation development, right? So what that means is that you've got developmental trauma alters your brain's threat detection systems, right? So your amygdala becomes sensitized, your stress response becomes really hypersensitive and becomes easily activated. You start to expect danger all the time, even when it's not present. And from a safety perspective, from a neurobiological perspective, that's what happens, and it makes sense. So if a child grows up in unpredictable or frightening environments, the brain will adapt, right? It will become vigilant, it will scan for potential danger all the time. And that, along with those circuits that we've just talked about, and using those circuits, can become obsessive, right? So part of the adaptation to danger and risk is to obsess about danger and risk. Okay, so your brain will constantly say, what if something bad happens? How do I prevent that? What do I do? And your obsession, so all the obsessions, all the fears that when you look into someone with OCD and try and identify their obsessions, you will find that every one of those obsessions is an attempt to predict danger. Right? So the OCD, the obsession is the prediction of danger, the compulsion is your attempt to control it. Right? And when you think about developmental trauma, and it kind of turns up the dial on that system, doesn't it? Because you've got this, if you've already got a genetic vulnerability, experiencing developmental trauma means it just turns up the dial of that hypervigilant state. Okay, and you also, and we know that developmental trauma impairs the development of your stress regulation system. Right? So that together is going to make it, you're going to be more likely to have trouble regulating these obsessive compulsive circuits. There's lots of overlap between neurodivergent conditions like autism and ADHD and OCD. Right? They all get executive dysfunction. There is definitely elements of repetitive behaviours in ASD and OCD, and to some degree ADHD. Right? So how many reels do we see about people doing, saying my ADHD makes me do these things over and over again? There's definitely emotional dysregulation. There's definitely sensory sensitivity, and there's clear social difficulties. Right? And it is definitely more prevalent in those who have neurodivergent conditions. And there's high comorbidity between them all. And in fact, trying to work out what's what is actually really, really tricky. Because, and so how do we then understand this? Right? Because you might have, how do we work out whether the obsession and the compulsions are because of an OCD circuit or because, you're experiencing sensory threat and you're misinterpreting sensory threat as or over-interpreting sensory threat. So, because we know that in autism there's sensory processing difficulties. They're not. If you have autism, you really need things to be predictable, because slight changes your brain will interpret as potential risk, and you're cognitively not very flexible, which really sets you up for being obsessive. Yeah? And it means that your stress response, even a slight unpredictability of your environment, your stress response is going to be huge. Right? So rituals and repetitive behaviours will create stability. They reduce kind of your cognitive load, because you've kind of got this kind of repetitive pattern. When I feel this, I just do this. I don't have to think about it, so I don't feel as stressed. And in ADHD, there's an alteration in dopamine regulation. We don't, in ADHD, we can't, kind of our brain's way of processing reward systems and anticipating rewards is not typical. Well, nothing, everything feels boring. And we know that the basal ganglia and those kind of habit circuits or those regulation circuits are implicated in all of these conditions, right? Because they all intersect. So it's actually really, really difficult to tease out one or the other. Right? But even though we've got sort of different, we might describe it as different needs. Like the ADHD person says, I need to see something, I need to see novelty, whereas the person with ASD says, I actually need sameness. Right? Different needs, but the same circuits and the same purpose, which is to relieve anxiety and to control, right? And you know, because by craving novelty, you're kind of giving yourself this, you know, it's in some way a relieving mechanism for your stress or your anxiety. So when we treat people with OCD or ASD or ADHD, or more commonly all of the above, it's important to remember that there's intersecting neurobiological systems. And so therefore, treating, what this means is that, you know, treatments for ADHD, treatments for ASD related symptoms might also make an impact in improving OCD symptoms and vice versa. Does that make sense? But the core message being that they're not doing it on purpose. Predictability is probably the safest place to go for them, but also there needs to be a little bit of flexibility, right? And so your challenge is then how do you, you know, so in OCD treatment, there's always this challenge of how do you challenge at a step that's small enough that doesn't cause you to shut down, right? But you're kind of still practicing that mental flexibility. That's the whole task of OCD treatment. And it's the same in autism and ADHD. Trichotillomania, a really, really difficult condition to face and to treat. So, you know, and the group of it is, it belongs in a group of conditions called body-focused repetitive behaviours, which is, you know, reasonably common enough. You know, interestingly, much more common in women, in adults, and you know, we don't really fully understand why that is yet. But it's classified under the obsessive compulsive and related disorders in the DSM, and it can have sensory components like picking, but also, you know, like it's a behavioural component of the rituals. Okay, so there's the OCD obsessional kind of loop is still there, but it manifests in this repetitive behaviour. Okay, and the thing about trichotillomania, similar to OCD, is this thing about perfectionism. Like it has to be perfect. You have to pull the right hair at the right, on the right, and it needs to feel right. And if it doesn't feel right, you need to pull again. Right, like washing your hands. You know, like it's a similar thing, but it's driven by sensory needs. Right? So in some people, it can be very, very focused with that perfectionistic trait, and others, it's just people don't realize, or they wake up with clumps of hair in their hands, right? And without awareness. Not necessarily they're doing it in their sleep, but they might not necessarily be fully awake while they're doing it. But also that in trichotillomania, there's this really interesting phenomenon where many people actually describe a build-up. There's a build-up of tension, right, in trichotillomania. Like this is so it's not quite like the obsession that's like quick. You think about it, I'm compulsed to do something. Trichotillomania has got this ramp, right? For some reason, this is kind of build up, and perhaps some of it is because there's a resistance from the person because they kind of know that they shouldn't pull their hair because it doesn't look great, and so there's this kind of ramp up of discomfort, and then as soon as you pull, there's this immediate relief, right? Like, and that's the loop. Right, that's the OCD loop, and the good thing about it is, well, not necessarily a good thing, but that feature does allow you to work in that ramping up phase, because generally there is a ramping up phase, whereas the OCD rituals, whether it's checking or tapping or washing, it seems to be quicker. So trichotillomania has got a little bit more scope in that prior build-up phase, if you can find a different way to use sensory pathways and kind of other reward circuits to help your brain not do the action, because there's a time, you know, there's kind of a little bit of time, whereas in other OCD behaviours there might not be as much time. But I guess, you know, and we know that the same, in trichotillomania we have the same dopamine signalling and striatal involvement. It's very similar in brain circuits to OCD, and what it is you're still really, the child or the person is really still attempting to manage an overwhelming feeling, with that action. So that, so that's why treatment has to include ways to manage stress, recognizing the ramp, any sensory related habits that we, that we think about, these behaviors and these body focused repetitive behaviors as sensory related habits that have been reinforced, and it's not self-harm, right? Which is something that's been said sometimes, where you kind of go, is it a way of harming yourself? Not trichotillomania. There are definitely lots of different ways that people can self-harm, but this hair pulling seems to be a real, it's this obsessive compulsive repetitive habit that's really, really difficult to stop, but an experiential mode of treatment helps in the long term. So how do we reframe this, right? So what are some things that we can do? So what we can do is that we need to shift our thinking around OCD and trichotillomania, that instead of asking how do we stop this behavior, we ask what problem is this behavior solving for them? That's actually the key, right? That instead of focusing on the pathology, we acknowledge that the pathology or the behavior or the symptom has occurred because of their brain's way of coping to an environmental challenge, right? It might regulate anxiety, it might regulate sensory overload, it might provide predictability, or it might recreate, familiar threat response patterns from the past, and there are certainly some of those, whether it's the ritualistic thought or the action that you can see has really come about from the past. And if we understand that these are protective functions and these are kind of survival behaviors, we can then start to think about, well, what is the problem here? What are they trying to relieve? What is the problem that they're trying to solve? That's the key, because that's where you'll get to the solution of how to reduce the behaviors. Otherwise, you end up, because what do you do if you focus on the behaviors? What happens? You end up in a battle that you're not going to win, because they actually can't stop it. You can't say just stop it. You can't say just resist. Just resist. That doesn't work either, right? It will cause more distress. They'll have, they might resist that action, but there's still going to be a need to relieve that in some other way, because you haven't addressed the underlying problem, right? And that there are underlying problems that the behavior is trying to solve. Which means that the people around them and that the treatment approach needs to be experiential, right? That the most powerful, so we accept that the most powerful regulator of a child's nervous system is a safe relationship. And if you're a child, that safe relationship should be with your trusted attachment figure. Right? And we don't argue. We don't argue that that the parent-child relationship directly influences their nervous system. That when the child feels safe, their defense system stabilizes, their stress hormones decrease, their frontal lobe function increases, which means you're regulating your emotions much better. And your brain learns, right? And one of the things it starts with is that your brain first learns that there is external regulation that's available to them. So what we call co-regulation, right? So there has to be attunement, there has to be a development of attachment and trust, and then this co-regulation, right? Because if you have a child who experiences distress and doesn't know what to do with it, what do we do first? We turn to our caregiver to co-regulate us. So the child experiences there's external regulation available to them, and that's the magic of being human. Right? That being human, we actually are regulated by calm, safe adults around us or caregivers around us, especially as a child. And when we are adults, we also feel regulated by other adults who are warm, acknowledge us, right? And appear regulated themselves. So what does that do? When the child sees that there's external regulation available to them, they don't have to resort to those unhelpful ways to regulate themselves. Right? So there's less need to activate those circuits. Then eventually there's an internalization of that capacity to self-regulate. And that's what happens. That co-regulation leads to self-regulation. So every parent that asks us, how do we teach my child to regulate their own emotions? There's a really clear answer. You need to go back to the co-regulation. Right? Because if they haven't learned that, it means they probably didn't experience co-regulation. And let's make sure that we're not blaming parents here, because parents are doing their best. But perhaps some other factors meant that your parent couldn't co-regulate you because they couldn't self-regulate themselves. Right? And there's a kind of popular saying that says that, it's really hard to do to others if it wasn't done to you. If you didn't experience it, it's actually really hard to do it to your own child. Right? So it's something that you kind of have to. Sometimes it's luck. You have a grandma or other people who you become your sort of surrogate parents that teach you about co-regulation, and that's how you learn it. And eventually you get to the point, my mum was doing her best, even though I was really mad at her. Eventually you get to that point, you're going, okay, she was actually doing her best, she just didn't know how. Right? So that's kind of part of that maturity that can happen in a human being. But co-regulation is still the way to help this problem. Right? How do we treat BPD or complex trauma? Right? What are the modules of DBT, Sal? Hence why I'm asking you the question, Sally. What are they? Right? So distress tolerance, number one, okay? And what are the two key things, right? Distress tolerance and interpersonal effectiveness, right? Which is about one, tolerating your distress, managing your distress, and then two, being able to cope in the presence of others, right? And to learn how to build trust, right? Because to me, BPD is a problem of trust. You don't trust people, you don't trust the world, you don't even trust yourself. Right? And but slowly in therapeutic relationships, and I say that with plural because it's not just about the therapist, it's about the people around you. Your therapeutic journey is going to be much quicker if you have therapeutic people around you. What's the evidence of in substance use disorders? What helps them recover? Community. Right? Always. Relationships, always. And OCD is no different. Trichotillomania is no different. Right? So every time I get asked about, more medication for OCD or for tics or for, right? I'm always going to ask that next bit. And yes, we can think about medication and what's happening in your relationships. And I don't take it's fine for an answer in practice, right? So if we think about, let's say this, your 10-year-old boy who repeatedly asks his mum if the house is going to burn down tonight while we're sleeping, right? I actually know a kid who asked this question, right? Every night it's the same question: Is something bad going to happen? And what's mum do? Reassures, of course not. Of course not going to happen. Don't think about it that way. Right? Don't think about it like that. And the questions get worse. Right? Until you get frustrated. Right? Or you ignore it. You go, I'm not going to answer that question because it doesn't make any sense. Which brings us, and it does for a 10-year-old or a young child, the concept of reassurance is important to talk about here. That our first parenting 101 is to reassure. We always reassure the child immediately. What do we say? That's not true. That's not going to happen. Don't think about it that way. That's wrong. Okay? Which is not. It comes from the right place. What are we trying to do? We're trying to reassure them. But sometimes, and we've talked about this before, sometimes how can that be experienced by a child? Great, right? It can be, so reassurance too early without connection is experienced as invalidation, which means I'm not going to tell you anymore. I'm just going to internalize it and deal with it with my compulsive ways. That's how simple these patterns can form, right? Again, there's a genetic vulnerability, there's developmental trauma, there's environmental stress that impact all of this. But this is why parents go, what did we do wrong? We didn't do anything wrong. But sometimes the patterns of your communication and your relationship actually reinforce these things, and you didn't realize it because no one taught you. No one told you that that's what happens when you reassure your child too early, right? That when you ignore them, they're actually really, really struggling, and your child's brain's trying to manage uncertainty. So how do we shift, right? If we now know that this is hyperactive error detection, right? That your child's brain there's actually a circuit going on in there that's trying to protect them. That's a bit too effective. You've got to shift your response, right? Now that you know that, right? I can see your brain's really worried tonight. Let's sit together for a few minutes and let me help your body settle. I'll stay with you until your body settles. Don't deal like the house burning down is the red herring. Like there's actually, like you acknowledge it, but if you don't, it's like dealing with the compulsive behavior. If you don't address the fear underneath, because that's what the 10-year-old's feeling. The 10-year-old's feeling scared and a need for connection because the transition from awake to sleep is a difficult one in that moment. Not always, but sometimes it can be because what happened today or what happened at school, or there's thoughts that, my 4-year-old saw a picture book about a zombie, and he threw that book in the bin and struggled to sleep that night, right? And needed a parent to stay there until he could, And if you can do that, again, it's there's obviously other things like habit formation that you can do. If you just go, it's just easier if I just sleep there all the time, then you might be creating other habits, right? There has to be flexibility. But first and foremost, you have to acknowledge the fear and support them in that regulation, okay? Now, what about the teenager who pulls her hair when she's studying, right? And so what do we do? Stop that. I'm going to put oil on your hair. I'm going to put cotton gloves on your hands. Do all sorts of things to try and stop you, right? To try and stop you from doing that. And look, and that for some people, eventually, that might go, okay, I'm going to reverse that habit. Because sometimes going cold turkey on a habit can work sometimes for some people. But for a lot of people, it doesn't. Because what's actually happening for her is that she's really experiencing intense cognitive overload. She's trying to study, my brain's too full, I can't do this. And I'm feeling this tension, and when I pull my hair, it relieves that tension. Okay, and what she's doing is using sensory regulation during cognitive demands. When we've seen I was watching some cognitive assessments, and 10-year-old girl was trying to answer the questions while rolling around on the table because she needed that pressure on her tummy, whereas someone else was jumping up and down on the chair. Like, we use sensory means to regulate cognitive tension. We all do that. If we ask you hard questions, I bet you're going to start doing something. Right? We all do. That's what happens. And for some people, it becomes pulling hair. Right? So what do? We might introduce other sensory regulation strategies. We might introduce some sensory tools. We might schedule in some movement breaks for her. Make sure that she's got timing that can relieve that tension, and there's a parent that can co-regulate when she needs it, right? If those routines don't help. So the goal is not just simply to stop the behavior, the goal is to help the nervous system regulate in a different way that's more helpful and more flexible. And that's going to take time. Okay, so, in summary, we need to remember that OCD and trichotillomania, we need to look at it through a developmental and neurobiological lens, right? That the brain is trying to solve a problem. It's trying to predict danger. It's trying to control uncertainty. It's trying to regulate distress, regulate this discomfort, something not right. The behaviours aren't random. They are specific to that person, and it relieves the distress. And they're always adaptive responses that have become learned over time for whatever reason. And we've talked about the combination of developmental trauma, lack of co-regulation, the wrong brain, right? In the end, they become overlearned. So our key role when we're trying to help someone with this, whether you're a clinician or a parent, is to understand what the nervous system is trying to achieve. What is the problem that it's trying to solve? Okay, so then we can help the person find different ways to achieve that goal, to solve that problem. And as you know, with my bias, the most powerful intervention is not a technique. It's the presence of a calm other, a trusted other, a regulated other who can share the load of regulating that feeling. Okay, and we really, really, really need to hang our hat on that. That co-regulation will lead to internalized self-regulation. Always does. In a safe environment, yeah? Because the brain doesn't grow up in isolation. It certainly doesn't heal in isolation. We are human beings. We exist in relationships. And that's the secret.